Good morning or good afternoon, wherever you're joining from. I want to thank the organizers of this ASCO Africa virtual meeting, where we'll be discussing some of the abstracts. And my names are Dr. Matilda Ong'ondi. I work at the Kenyatta National Hospital as a physician and clinical hemato-oncologist. And I'm going to be discussing with you the OPTIC trial. So I'm going to share my screen so that we can review this together. So the OPTIC trial was a trial looking at optimizing ponatinib treatment in chronic phase CML. And just a little bit of background. Just trying to advance my slides there. There we go. Just a little bit of background. We know that since the advent of the first generation TKIs, Gleevec, there's been development of many more. We have three options for the second generation TKIs, and that is nilotinib, dasatinib, and bosutinib. And what we'll be discussing today is the third generation TKI, that is ponatinib. So we know that it blocks both your mutated and unmutated BCR-ABL, and most important is a gatekeeper mutation, and that's the T315I mutation. Studies which were done earlier informed the dosing decision of 45 milligrams, and this is what was used in the pivotal PACE trial that looked at using ponatinib in patients who've been resistant to 2 or more TKIs or have Philadelphia positive ALL. And what was important is that regardless of the baseline BCR-ABL mutation, we see that many of the patients actually did very well. And when this cohort was studied and looked at 5 years later, they still had a deep and durable response. So that's important that the response they attained was actually maintained. Of note is that 55% of this cohort had a dose reduction, and at least 67% had at least one dose interruption. The EPIC trial tried to look at, can ponatinib be used in the frontline setting? And unfortunately, the study had to be terminated early due to the increased arterial occlusive events. And therefore, what we know now is ponatinib cannot be used in the frontline setting unless maybe in the future we get more information, especially with regard to finding a dose that doesn't have a lot of side effects. And that's really the meat of the discussion today. Just trying to figure out what is this dose that is able to give you a good response and not have too many adverse events. And what was shown in a post hoc analysis is that of the PACE data is there's a relationship between the dose and the response as well as the adverse events, and that those who had a lower dose seemed to have lower adverse events. Is this relevant in our setup? Yes. In Kenya, we have the GPAP program, for which majority of our patients are on imatinib as a first-line TKI, but increasingly we're seeing that for those patients who get resistance to the second-generation TKIs or are found to have the T315I mutation, then we need to put them on ponatinib, and we have 15 patients on ponatinib. So this was an interim analysis. You can see all the sites that were involved. It was a multi-center trial, and again, it was just looking at chronic phase CML. So the important thing is that patients needed to have at least been on 2 or more prior TKIs and shown to be resistant to that, or have expressed the BCR T315I mutation, and not have any uncontrolled cardiovascular disease. And if this was present, that it needed to be well controlled. And we can see the dosing variations. We had 15 milligrams, 30 milligrams, 45, and this randomization was in a 1-to-1. And the primary endpoint for this study was patients to have or achieve BCR-ABL of less than or equal to 1% at 12 months. And once patients achieved this, then they could be dose reduced to 15 milligrams, and that's very important. And the secondary endpoints are as listed there. So this is the demographics and the baseline characteristics for the study cohort. And as mentioned earlier, most of these patients, by virtue of the group that was selected, were heavily pre-treated. And the important thing is that many had had their TKI stopped due to resistance. Of the cohort, at least 77% were able to be evaluated for the primary endpoint. And the other important thing is that we see, especially for those who are on the higher dosing, 45 milligrams and 30 milligrams, that their dose intensity was actually much lower than the dose that they started off with. And they had a good follow-up across all the groups. So as expected, for those patients who had the higher dosing, which was 45 milligrams, they had a better response. You had a higher proportion. And also important is that there was also a response with the 30 milligrams and the 15 milligrams. So the lower dose didn't mean that the patients don't respond at all, but you can see that this efficacy is dose dependent, being higher with the higher the dose of ponatinib. Another important thing, because as we mentioned earlier, this study allowed that once patients met the primary endpoint, their dose could be reduced, and that beyond 90 days, for those whose dose was reduced, they actually maintained that response. And for those patients whose dose was reduced and they lost the response, then they were reinitiated or the dose was re-escalated, and a fraction of those patients responded. So indeed, it's important to note that if you reduce the dose, monitor the patient, and some of those patients whom have lost their response, once you re-escalate the dose, then they regain the response, which is important. So what we saw in the earlier graph was that all doses have at least a response at baseline, and we see that this response is much higher or is dose dependent. Being higher, the higher the dose you're using. The other thing is that when we looked at the T315I mutation as compared to those who didn't have the T315I mutation, this is important. The response in patients who had a T315I mutation is dose dependent. So markedly lower response, actually much lower than what was seen in those who did not have the T315I mutation. Therefore, for this particular group of patients, it's very important to try and maintain the higher dose if possible. Again, the progression-free survival and the overall survival for this cohort was actually good, well above the 80s across all the dose ranges, seemed to separate and be slightly lower once the time point was, beyond 2 years, but this will wait to be seen once the study is over a longer period of time. When we look at the adverse events, we see that still we have to monitor them for cardiovascular adverse events, but those slightly less, especially the grade 3 adverse events were slightly less. The other important thing is the hematological adverse events, especially thrombocytopenia, because one of the things, like in experience we have seen with our patients, is that at the time you're thinking of switching them to ponatinib, they already have significant thrombocytopenia, and therefore platelet support at this point would be very important, and also being cognizant that starting them on the ponatinib would actually make it worse. So one of the other things we noticed that the adverse events were more the higher the dosing. And this led, of course, to dose reductions and interruptions, but this was slightly higher, the higher the dose. So if you compare the dose reductions or interruptions with the 45 milligrams and the 15 milligram cohort, then the ones in the 45 milligrams was slightly more. So really, this is the summary of what this study shows, that indeed the response or the efficacy is dose dependent. The higher the dose, the better the response. But we also see that the adverse events are there, increase as the dose increases, but with this particular strategy, then you actually reduce the proportion or the percentage of the adverse events that you experience. So the conclusion is, when ponatinib is effective in all 3 doses, the best response is seen at the 45 milligrams, and this is maintained despite tapering that dose to 15 milligrams once the BCR-ABL is achieved. So this is very important, that the taper is done once the endpoint has been achieved, and that with this strategy, there seems to be a side effect profile. Again, as mentioned earlier, this is an interim analysis, and it'll be interesting to see how the data looks like once the study period is complete. So thank you very much. We look forward to seeing what questions arise during the Q&A session. So thank you.